all. I hope we are audible from our end. So welcome all to 15th session. Today we have Smriti ma'am taking a session on addiction for us. So we can start with ma'am's presentation followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Vaishnavi.
Thank you. I'm so happy to see you all again. So we have our 15th session on addiction. We all know who is SMRITA Rana, but again, for the formal introduction, I would say she's the program and project director of Palim India, and she's the she's specialized in psychology and child palliative care, children in palliative care also. So over to you, ma'am. We are expecting a wonderful session ahead.
Thanks,
as always.
Thank you. Thanks a lot, and good to see everybody again. Today's session, like Raju and Vaishnavi said, is on addiction. But before we go any further, I just want to put out a bit of a disclaimer. Typically, we have a case presentation when we do our echo sessions. We're not having one today because I specifically requested that we spend more time on the subject topic itself. The topic of addiction is very, very complex. And so it has many nuances. It has many emerging theories about it. So just going forward, setting the expectation for this session, I feel that we will be talking about a lot of different aspects of it, and to really give specific treatment interventions in the context of addiction is not something I'm going to do in this session. This is more of an introduction to the idea and theory and science and the art of understanding what addiction is. And I'm sure this session will leave you with more questions than answers. That is something that I'm pretty certain of, but that is not a bad thing, because I hope that the questions that arise in your mind will lead you to do more research. And of course, we can always get back in touch and we can talk about specific scenarios that you all might be facing. But please bear with me. Consider this an introductory session to addiction. I have been deeply interested in the subject of addiction for a while now, but even as somebody who's been so interested and has done a fair bit of research, I still find it a very complex subject. I'm just going to introduce it from my point of view, and I will be adding a little element of addiction within the palliative care context, but largely we're dealing with the overarching themes. So I'm just going to start sharing the screen, the presentation with you now. Is the screen visible, Raju, to everyone? Raj Lakshmi, is the screen clear?
Yes, ma'am, we can see it.
Okay. So addiction and dependence. Now, firstly, I'm going to ask you all to take a moment to think about what is addiction and who is an addict. I'm sure when you hear the word addict, there's a particular visual that you might have in your mind of what an addict looks like. So I'm going to ask you all now to take a minute and maybe give me some feedback on what is the kind of visual that comes to your mind when I say the word addict or I say the word addiction. No right or wrong answers. This is all that we've all been exposed to. So I'd just like to hear from you.
Please raise your hands so that we can unmute. Yeah, Pranab Kumar sir.
Am I audible?
Yes, sir.
Am I audible?
Yes.
Addiction means what a person is prone to take some alcoholic or some medicine which causes him or her pleasurable condition to adapt. and side effects also. Am I
Thank you.
clear?
Yes, yes. I'm also going to ask in this case, we all have a picture in our minds of what an addict looks like. I'm sure that socially, I mean, this is not just to you, sir, this is a general. What does an addict look like in your head? Or is there a certain persona that we ascribe to somebody we consider an addict? I'll tell you, in my family, some of the people in my family, the minute you say addict, they're thinking the worst thing. They're thinking of somebody who's shabby, who's on the streets, who's using syringes, has no moral compass. I mean, there are people I've come across who that is typically what they see an addict as. So I'm just saying that we all have pictures in our mind about what an addict stereotypically looks like. So if anybody would like to say something, then I'd love to hear it. Otherwise, we can move on.
Yeah, from our part, addiction is something we are so fond of. Certain times we can't remove it from our side, our life.
Yeah.
It's not only related to alcohol or any kind of medications, but it's also something very immaterial too.
Thank you, Vaishnavi. That's a very important. So moving ahead, typically, traditionally, we assume that addiction is the equivalent of a dysfunctional dependence on a drug, right? That's ordinarily that's what comes to mind. But you'd be surprised to know that this particular interpretation is just about 100 years old. It's actually a new idea. I mean, 100 years in the history of mankind is actually not that long if you think about it. So the interpretation of addiction as we currently know it is just about 100 years old. The history of it is, earlier the word addiction only referred to an activity that one was passionate about. It's even been used in the context of, oh, that person is addicted to agricultural practices. I mean, something as random as that. The root of the word is adicere, which means to assign, and like a habitual activity with a positive purpose. That was the root of the word. But it was actually the Romans who changed the whole meaning, and they called a person who didn't pay his debt back, they called him an addictus. And he was then assigned to the person that he had taken the loan from as a slave. And that's how today we get the understanding of the word addiction to mean, a slave to a habit. So that is the etymology of the word. And I just thought it was interesting to know where that word came from. And but today we talk about dependence syndrome. And this is a definition that came up with the 10th revision of the International Classification of Diseases and Health. The ICD-10 is something that the WHO, it's a coding system that the WHO introduced. And according to that, they actually introduced the word dependence, which means a cluster of physiological, behavioral, and cognitive phenomena in which the use of a substance or a class of substances takes on a much higher priority for a given individual than other behaviors that once had greater value. So basically what it means, what they're saying is that the need to take this substance goes beyond anything else, any other priority in his or her life. So that's currently where dependence syndrome is in terms of definition. But I'd like to bring your attention to the fact that there are different ways of addressing this. There's addiction, as we spoke, there's dependence, and there's abuse. And I would really like to highlight this fact that these three words are not interchangeable with each other. You cannot automatically use the word abuse when you want to say addiction. Dependence is very different from addiction. So this is something that I'd like all of us to be mindful of when we use the term, and we need to understand what term is appropriate in what setting. So, for example, a person can be dependent on a drug but not addicted to it. An example of that would be if you have high cholesterol and you need to take statins. You're not addicted to the drug. Your body is dependent on it. You are dependent on it to maintain health. A person who is diabetic is not addicted to insulin, but they're dependent on insulin. Similarly, a person who is in pain is physically dependent on opioids. It's not necessarily addicted to opioids. Okay. We also we come across this idea of tolerance. Like if you keep taking a drug for pleasurable experiences, you're going to need more and more of that drug to to stimulate the senses. But a person need not have developed tolerance to a drug to be addicted. There are people who don't need to take excessive amounts of the drug, but they need to take the drug anyway. So tolerance is not necessarily, the absence or presence of tolerance does not actually define addiction. And finally, when we study addiction, very often we're told that a person who's addicted to a drug, when the drug is taken away, they have withdrawal symptoms, and that is a very classic sign of the person being addicted to that drug. But that's not true. If you were being treated for tuberculosis, if any of you have ever experienced it or experienced patients who have gone through that whole regimen, there is a withdrawal period that the person goes through after the drug is discontinued, after its entire course has been run. So just because a person has withdrawal symptoms doesn't mean they're addicted to the drug. It means that the drug had those side effects, it had that impact on the body, and once those chemicals have been taken out, then of course the body takes some time to adapt to the absence of the drug. So these three things, tolerance, withdrawal, dependence, they don't in and of themselves define addiction as we know it. So that is something to be mindful of also as we go forward. This is what actually addiction requires. These are the components to really diagnose addiction. There has to be a compulsive engagement with a particular kind of behavior, and there has to be a preoccupation. If somebody is addicted to alcohol, there's a preoccupation in their mind. Where are they going to get their next drink? Where are they going to, there's a dry day coming up, I better stock up. If somebody is addicted to nicotine, they're going to wonder where their next packet of cigarettes is going to come from. If somebody is addicted to heroin, they're going to think about their next hit. In fact, it becomes the most sort of priority thought in their minds. The second component is impaired control over the behavior. A person who is addicted has no control over that impulse. They feel the need to have a cigarette. They feel the need to have this, to have a drink. It might be in the middle of the day, but they have no control over that impulse. The fourth is persistence or relapse despite evidence of harm. You smoke, yeah, everybody today knows the harm of smoking, what it does to your body, but they will continue to smoke. There is enough and more evidence out there in the world to talk about the negative effects of smoking, of various other substances. But people who have an addiction will continue to persist in that behavior, or sometimes they'll stop for a while, but they're at very high risk for relapse in spite of knowing the evidence. And lastly, I think, and this is a definitive component of addiction, there is an intense craving for it, for the substance. And if the drug is not available or that activity is not available, then that person is irritable, that person gets angry, they're not able to really relate to anybody else. So these four things: preoccupation, impaired control, persistence in that behavior, and an intense craving for the substance. These are the four main components that really define whether somebody is addicted or not. But it's not just substances that people are addicted to. There are several behaviors besides substance use that produce the same kind of short-term reward that may result in persistent behavior despite knowledge of adverse consequences. And we're going to talk about what some of these behaviors are. But here it's interesting to note that the minute we talk about addiction, the first thing that that comes up in our minds is of substance abuse and of actually taking something that has a pleasurable sort of influence. But there are many behaviors that all of us as people in our regular lives engage in, which have components of addiction to it as well. And I'm sure all of you are thinking about it now. What are you addicted to? Neuroscientific data now has led to the inclusion of non-substance behavioral addictions in what we psychologists consider a Bible, the Diagnostic and Statistical Manual of Disorders, of Mental Health Disorders. And the 5th edition, which is the latest edition, has included behavioral addictions as well as substance addiction. Now, all addictions, whether they are to drugs or to non-drug behaviors, actually utilize the same brain circuitry and the same brain chemicals. And the purpose of that brain circuit and the purpose of those brain chemicals is to create an alternate physiological state. Okay, so whether it's a substance addiction or a non-substance use behavior, the brain circuitry is the same. Having said that, we have to avoid the trap of believing that addictions are a biological condition. very often I've heard people say that, oh, it's a disease. It's just a biological condition, and it's, imbalance of chemicals. So it's very easy to take the biological view. But when you take the biological view, unfortunately, what happens there is that you only look at it from the biological perspective. You treat it as a disease when it's actually so much more. And so what I would say is, as we go along, we look at some of the other aspects. This is actually what addiction looks like. And let me tell you, it took me a very long time to get all these things on one circle in one page. And there are 10 things there. So I'm going to go through it. There's the biological component. There's a chemical component. There's a neurological component. There's a psychological component, a medical one, emotional, social, political, economic, and spiritual. And addiction is a complex interaction between all these things. Why political? Why social? What does politics have to do with addiction? You'd be surprised how much it does. If you go back, I'm just going to digress a little bit. This is something, if you're interested in, especially our friends from the northeast of India, there's a lot of literature on this, where indigenous communities across the world, whether they've been in South America or in Canada or in the Indian subcontinent, have always used certain plant-based substances for ritual, for rites of passage, for sacrament. And this has been part and parcel of their culture for hundreds and thousands of years. But the problem of addiction, as we know it today, came in with colonization. I know that's a very controversial thing to say, but there is enough data to back that up, where addictive behaviors were also introduced in order to sort of control the population a little bit. And if any of you are interested, through Raju, I'm happy to share some literature on that is ongoing as well. One of our biggest advocates to the United Nations from the IHPC, the International Association of Hospice and Palliative Care, Catherine Pettis, has written an incredible chapter on the impact of colonization on addiction behaviors and drug control. So politics does play a role. I was recently at a drug control and human rights conference where a very interesting slide was presented, where they said that today, why do we view addiction as a problem, or how it evolved as a problem of society? Apparently, in America, there was a time when the far left anti-war crowd and people of color were the biggest threat to the political system at that time. So what did they do? It was illegal for them to go in after the people of color. It was illegal for them to go after people who were demonstrating against the war. So they associated drugs like cannabis to the far left, and they associated drugs like heroin to the people of color. And that gave them the power to go in and disassemble these groups. So there was a very clear political motive. And the Secretary of State at that point actually went on to say, yes, did we know that drugs were not the real problem? We did. So I'm just telling you the story to highlight, because I think some of you might wonder why I've put political as a component. But in our understanding of addiction today, politics, sociopolitics do play a role. So, of course, the rest of it is, there's enough and more evidence. We're all more familiar with the rest of it, like biological, chemical, neurological, but I'll touch upon those also as we go along. Coming specifically to the context of behavioral addiction, it is defined as an intense desire to repeat some action that is pleasurable or perceived to improve well-being or capable of alleviating some personal distress, despite the awareness that such an action may have negative consequences. So this is entirely behavioral based, okay? And from a psychological, neurological, and social standpoint, such repeated patterns of actions, which are characterized as addictive behavior, also include drug and alcohol addiction. So there's an overlap here. But what we're essentially saying is that, what I said earlier, the circuitry is the same. Some of the more serious behavioral addictions include pathological gambling, trichotillomania, which is the urge to pluck out hair, pyromania, which is the impulsive, repetitive, and deliberate fire setting without external reward. And there are people who actually love, starting fires. Kleptomania, I think this is a more familiar territory for a lot of us. impulsive stealing behavior without any objective need to do so. I've heard so many stories of people who actually come from like well-off families, and they're from affluence, and they have this they have this uh, tendency to just steal whatever they can, and it's not because they need it, because they have enough money to buy it, but it's that need to steal something. So that's kleptomania. Compulsive impulsive internet addiction, I think this is something that is more close to home to all of us. I mean, how often between your work do you reach for your phone and check Facebook or Instagram, and it is an addiction. It is an addiction. So I'm not calling you addicts, but or myself rather, but this comes under the same category. And believe it or not, the same circuitry that is lit up with a drug abuse problem, the same circuitry is lit up with even checking your phone 100 times a day to check social media posts. And of course, compulsive impulsive skin picking, that's one of the other things that have been identified. Historically, these have all been known as impulse control disorders. And of course, today you'll come across different phrases like behavioral addictions, process addictions, impulsive compulsive behavior. These all mean the same thing. People use different terminology, so don't get confused by that. But the critical phrase here is impulse, right? There's no control over impulse. Also, compulsive activities may include stuff like, again, we've talked about gambling, eating disorders, bulimia, anorexia also have a compulsive component to it. Sex, there are people who are addicted to sex, and that leads them, and it's not for the pleasure of it. There's another aspect to it as well. Shopping, how many of us are familiar with that? And I think one of the worst things that happened was the introduction of online shopping, because now you don't even have to go to the store, do you? You just have to get on your phone. The one more reason to be addicted to your phone. Working, this is one of the most acceptable forms of addiction. We respect people who are workaholics. But if you look at it, when we go back to the definition of addiction, even though it has an adverse effect, a person who is a workaholic, the adverse effect is less time with family. That is a massive adverse effect. But we continue to do it. Some people need to work, that's different. But there are people who are just addicted to the idea of working, and they're up all night doing all kinds of things. So, but this is something that society actually condones. We don't call that person an addict, but it's the same thing. There are people who are addicted to exercise, which is seen as a very healthy addiction, but it's an addiction nonetheless. TV watching, of course, we might know a lot of people who have this addiction. Relationships. This is an interesting one. Actually, the original phrase that was there, which I changed to relationships, was falling in love. There are people who love that idea of falling in love with somebody. That first rush in a relationship when the romance is just starting. And a lot of these people, they get into the relationship, after which it becomes boring. And then they break up and they move on to the next relationship for that rush. And then they move on to the next relationship for that rush. So it's addiction to that first phase of a relationship. So that is also the same circuitry in the brain that is being activated. There is, of course, much controversy in diagnosing, treating, or even naming some of these conditions, as many of these behaviors are daily rituals that are instrumental to ultimate survival. I mean, we need to shop, we need to eat. Sex is a part of everybody's lives. Work is a part of everybody's lives. So it's very, it has been a very controversial process, and it continues to be a controversial process to name when a normal behavior becomes an addictive behavior. So the frequency, the adverse effect, the persistence, the compulsivity. So all of those things. So there's ongoing discussions about these different things. But I just wanted to highlight that when we talk about addiction, we're not just talking about substance use, we're also talking about behavioral addiction. And this is something that it's also an exercise in empathy, because if you see yourself doing any of these things, then maybe we'll have more compassion for the people who have more severe forms of addiction. Talking about impulse control, we have to make the distinction here between that and something like obsessive compulsive disorder. Examples of obsessive compulsive disorder could be washing your hands, like just compulsive hand washing, counting to a particular number a few times, having, exact number of something on your desk. And, if that is moved, then you get upset about it. So there are various different forms of obsessive compulsive disorder, but which is different from addiction, because in OCDs, there is no craving. A person doesn't have a craving to wash their hands. Okay, it's more coming from a place of reducing anxiety rather than seeking pleasure. So just to be clear about how OCDs are different from other impulse control disorders, and there is no craving. So that's one of the major ways you can identify it. So I like this idea very much, because I think this is something that we as a society really need to adopt. Mere exposure to a substance or an activity does not result in addiction. To say, oh my God, that person better not give them marijuana because 100% they're going to get addicted. That's not true. It's like saying then giving somebody a deck of cards makes them a gambler. It's not true. There has to be a pre-existing vulnerability in the person. And I like this quote a lot from Lance Dodds. He says, addiction is a human problem that resides in people, not in the drug or the drug's capacity to produce physical effects. Now, I know some of you might be thinking, this is a bit of a stretch or leap in thought, but there's a very interesting study that was done on American soldiers who had served in the Vietnam War in the 1960s and 70s. Less than 1% of these soldiers, when they went out, were users of any substance before the war. While they were at war, a lot of them became regular users of heroin, barbiturates, and amphetamines, either to keep themselves awake during the war or to just, deal with the horror of war. And in some cases, the military actually encouraged the soldiers to take these drugs so that their performance was enhanced. And by the end of it, about 20% of these soldiers had met the criteria for an addiction diagnosis easily. So you would think that if they've gone into this place, they've started taking heroin and amphetamines and whatnot, when they come back, they must be addicted to it, and so they must want it. But shockingly, after the war, there was a remission rate of 95%. 95% of the soldiers who started taking heroin and amphetamines and barbiturates on a regular basis, when they came back to their home, they stopped taking the drug. So how does that work? What happened there? It defies logic. Actually, it doesn't. So this is why we say that mere exposure to a substance does not result in addiction. So I'm going to now move from behavioral addictions and focus entirely on substance addiction, because in itself, it is a huge and vast area, and I'm not even going to be able to cover 25% of it today, but we're just going to focus on this. It has been found that 3 factors need to coincide for substance addiction to occur. The person has to be susceptible. There has to be a drug with addictive potential. And I would think most importantly, stress. If any of these is missing, the likelihood of addiction falls significantly. But if all 3 of these are there, there's almost 100% chance of addiction happening. So these are the 3 things that need to coincide for addiction in its truest form to happen. So let's look at it a little more closely. What makes a person susceptible? Now, this is a bit of a technical slide, so I'm going to try and demystify it as much as possible. Each of these points that I have listed has a huge body of evidence behind it and a huge body of literature also behind it. And there is absolutely no way that it's humanly possible for me to take you through all of this today, but I'm going to try and just touch upon it. The most important, well, not the most important, but one of the things is genetic predisposition. And we've all heard this. There's a genetic component to addiction. Addiction patterns repeat themselves more significantly in families where there is a history of addiction. But that can be said of suicide as well. So if there's a history of substance abuse in a family, there is a good chance that the person is at high risk for being for becoming an addict himself or herself. Brain development in the uterus. This is now coming up. This is one of the newer sort of studies that are happening. And I'm not a medical doctor, so I'm not going to try and even attempt to go into the science of this. But there is good evidence to show what is going on as the fetus is developing in the uterus actually has an impact on whether that child will grow up later to have an addiction issue. Brain development during childhood. This is something that I can possibly explain with a little bit more confidence. It's in the first, and this is not a Freudian sort of thing. This is strongly based in biology and neurology. When a child is born, the first few years is a period of massive brain development. There are all these neural pathways that are being formed, and a human being is born with so many more neural pathways than they require, neurons that they require. So there's a process of culling that happens. It's called it's called synaptic pruning, where the brain starts cutting out neural pathways that are not required for by that person. So what happens is that the neural pathways that get used the most become stronger, and the ones that are disused slowly start to get culled. Think of this in terms of exercise. Like if you were to if you were to sort of exercise a particular group of muscles most often, that group of muscles is going to be the strongest versus a group of muscles that you barely ever use. And the interesting thing here is that the mind works the same way that the body works, that if you're in a situation of stress, you are likely to use the strongest muscle group or the strongest neural pathway. It says here that this is experience dependent rather than substance dependent, because here, let's remember, we're talking about addiction. So what does brain development in a child have to do with addiction in later years? How a child is treated by its primary caregiver really determines the emotional growth of the child. And let's not forget that the neural circuitry of the brain, there are dopamine circuitries, there are endorphin circuitries. Endorphin and morphine have a similarity in their etymology. Endorphin, because it is endemically present, it is something that is present in the body naturally, and it has the same sort of effect that an opioid might have. It has a soothing effect, it has a pain relieving effect, and so on and so forth. And how a child is nurtured will then affect how that circuitry also develops. And emotions are regulated through neurobiological development. So if a child has received a lot of love and all of that dopamine circuitry and that oxytocin circuitry and the endorphin circuitry will work naturally and healthily. I know it's getting a bit technical, I'm sorry about that, but I'm trying to keep it as simple as possible. I think maybe the next slide will be a little bit more clear. Emotional nurturance is an absolute requirement for healthy neurobiological brain development. This is something that is a simple statement of fact. We believe that a child's emotional well-being depends on emotional nurturance, but now we find that even the neurobiological brain development is dependent on emotional nurturance of the child. Okay. If a person has a genetic potential for addiction, it is the environment that activates it. Just because I have a genetic predisposition to addiction does not necessarily mean that I will become an addict. But if my environment pushes me in that direction, then my genetic predisposition will express itself. Okay. A child can feel emotional stress when a parent is physically present but emotionally unavailable. So it's not necessary that, when we think about how a person grows up, no, but he didn't come from a broken home. The parents were there throughout. I mean, it's not like he came from a family that there was a divorce or a death or whatever. But we have to acknowledge that a parent might be physically present but not emotionally available to a child, and that can be very, very damaging. And this is something that the psychologist Alan Shore has called proximal separation, being separate even while being next to one another. And children who have not received the attentive presence of a parent are at greater risk for seeking chemical satisfaction from external sources. This is again, evidence-based statement. And so I'm trying to connect up how addiction and childhood experiences link up. I hope that this is, making the link for you. Okay, so I'm just going to take a minute because I know this is a very heavy and technical thing that we just covered. So Raju, if there's any questions that anybody has on this particular segment on the impact of childhood experience on neurobiology and therefore on addiction, if anyone has any questions, now is probably a good time to take it while those questions are fresh.
Yes, ma'am. So you can raise your hands or unmute yourself and speak. CCF team, you wish to comment on the question?
So either I've explained it really well or really badly. It's one of the two. But I hope it's the first. I'm sure there will be questions. I'm happy to take it later also. If somebody wants to write into me privately, that's fine. Okay, so we're actually trudging through extremely, scientific sort of territory at the moment, but I think it's quite crucial to the understanding of addiction. I hope to be able to tie it up towards the end. Okay, so that is about who is susceptible. Let's also look at stress, the third part. So there was susceptibility, there was a presence of a potentially addictive substance, and the third was stress. I want to just bring that stress back to the point of view of illness and palliative care. The experience of illness is a massive, massive stressor in anybody's life. And it's not just for the patient, it's for the whole family, it's for close friends. And stress is such a major component. Now, if you go back to that study I told you about the Vietnamese, about the war in Vietnam and the American soldiers, a major component that was taken away when they came back home was stress. That part of the circle was removed, the stress of being at war. And to a lot of people, that is the direct correlation between why those people who came back were able to kick the habit of heroin and barbiturates and amphetamines, and why some of them continue to use it. The ones who continue to use it probably had a predisposition before they went to war, or they had stress at home and the availability of the drug. So stress is a very, very, very big part of addiction. So when we talk about addiction within families that we see in our palliative care services, are we missing an at-risk person in the family that is not the patient? Who are some of the people who could be going through massive stress as a result of that person's illness? The caregiver? Yeah. We actually know of cases where we were so focused on the patient that we missed this. And there have been a couple of instances where the caregiver has committed suicide, or the caregiver has become addicted. How many families do you know that you go and see where there is somebody in the family who has become an alcoholic? And, to me, I think a sad part of it is when we go in and suppose the patient has cancer and the patient's husband drinks, we immediately tend to look at him as a bad person. Like, your wife is sick, how could you be drinking alcohol? We don't stop to think that it's the stress of being in that position that could be actually aggravating this man's addiction. So let's be on the lookout for people who are going through that stress in illness settings, who are at risk for becoming addicted to a substance because of the stress that they're going through. Okay, so that's just a thought to keep aside for all of you. Now, I'm going to talk specifically about opioids and dependence. Because we are because we as Pallium India, we really encourage the use of the safe use of opioids. And very often in our practice, we come across doctors who have opiophobia, or families that have opiophobia, because they're like, hey, aren't opioids just addictive? I mean, opioids come from poppy, which is the same plant that heroin comes from. And historically, that has really given opioids a bad name, because people tend to equate heroin and morphine and everything else as the same thing. And one of the biggest challenges we as a palliative care community have to face is, getting people to accept that taking opioids for pain is not a bad thing. And the other problem we're facing today is that the opioid crisis in the West is having a downstream impact on us, because people are saying, look at what's happening in America. Do you really want to import that problem to India? But they're entirely different problems. We have to remember that. Now, coming to opioids as a group, there are two aspects to it. There's the physical dependence aspect, where when somebody is in pain and they take opioids like morphine, there can be some withdrawal symptoms on the discontinuation of the opioids. Once the pain is under control, you discontinue the opioids, and certain withdrawal symptoms might emerge. Low energy and sleepiness, disorientation and delirium, myoclonic jerky movements, like those uncontrolled muscle spasms, and abdominal cramps, diarrhea. These are some of the withdrawal symptoms that can come from opioids. But if we do a very slow withdrawal of opioids, we are able to control a lot of these things. If you suddenly take away the opioids, then you're likely to see these things happen. But if you do a slow tapering off of the drug, a lot of these symptoms can be controlled. That is physical dependence. The body is dependent on the medication. The other side to it is addiction. And this is what everyone is afraid of. How many times have you heard that? I don't want him to get addicted to morphine. I don't want my patient to be addicted. This is one of the biggest barriers we face today in access to essential medicines. Okay. Now, addiction from a psychological perspective has these components: craving for the substance. The person tends to slightly increase the dose. The person starts taking unsanctioned doses. He's been prescribed for 10 mg of morphine every 4 hours. He starts taking 20, or he takes 10 mg in the middle after 2 hours. And there are behavioral changes, like the person starts behaving funny, like he's trying to figure out where he's going to get that drug. There's a preoccupation with the drug. If you remember the first square of components that I showed you, there's a craving, there's a predisposition, there's an impulse control issue. So behavioral changes would indicate that the person is getting addicted to the drug. But this is very rare with oral morphine. And this is something that we all need to understand. Why is oral morphine less likely to cause addiction than another form? I want you to think about that for a second. Why is there less chance of somebody getting addicted to oral morphine than to, say, injectable morphine? So with oral morphine, it's the way the drug is metabolized. Okay, so oral morphine, you take it, you ingest it, it takes a certain amount of time for the drug to have an impact on your system. Whereas if you take IV, there's a peak rush, your blood levels peak, there's a rush that you get from it. That particular rush could be what causes the addiction, that sudden pleasurable experience, which is very, very, it doesn't happen with oral morphine. Okay, so that is something that when we are making a case for oral morphine in our own communities with our own decision and policy makers, that is something that we need to keep in mind. And that's actually something that we need to state, that the chances of addiction with oral morphine is negligible. And it's not a problem with cancer, because what it's really doing is combating the pain. This was a study done in 2001 by the Lancet Commission. This was something that Dr. Raj was part of. It was a result of a 2-year study in Kerala. And remember, this is 2001. This is prior to the amendment of the Narcotic Drugs and Psychotropic Substances Act. It was found that 1,723 patients, this was the cohort, 13.6 kgs of morphine was used. That's approximately 7.9 grams per patient. Kerala had a system for documentation, which was something that the rest of the country didn't have at the time. And when they looked into it, they found that there were no major unaccounted discrepancies. There was no diversion of morphine. And minor discrepancies that were there were investigated, and it was found that there was absolutely no misuse and no diversion. Nobody was taking morphine just for the heck of it. This is before the NDPS Act. This was actually one of the things that went in to strengthen the case for the NDPS amendment. Okay, so the reason I'm telling you this is to highlight the fact that oral morphine does not actually have the addictive properties that people ascribe to it. And where does that leave us as palliative care people? I don't know how many of you are familiar with the phrase, the principle of balance. If it is something that you're hearing for the first time, please write it down and please remember it, because it is actually one of the most crucial things that we need to fight for as a community of palliative care providers. The principle of balance basically states that we have a dual responsibility. One is we need to prevent the abuse of opioids. But the other part is we need to make opioids available for those in pain. Okay, so that is the principle of balance. Now, I would just like to highlight that with something that I put together. The reason the NDPS Act was brought in 1985 was a knee-jerk reaction to America's war on drugs. And suddenly, you know, there was this thing that, you know, we have to have this war on drugs. We have to stop people using these drugs. There's a lot of illicit use going on, etc., etc. And so the NDPS was brought in, and then what it resulted in was a massive rise of pain in our country. Now, the war on drugs stems from the international laws of criminal justice, which is basically focused on the prevention of diversion for illicit use. But on the other side of the scale are the international laws of human rights, which actually encourage availability of opioids for medical and scientific purposes. Very often this picture is tilted towards the international laws of criminal justice. Our own laws were so prohibitive because we were coming more from a stand of criminal justice rather than human rights. Today, as palliative care providers, we're asking for more human rights angles to come in. And public health actually sits right there in the middle. And this is where the principle of balance is. So in all our practice, let's become familiar with the principle of balance and what the principle of balance really means. That true public health can be achieved only if we balance these two out. And so that's as far as the legal aspect goes. But let's take a more compassionate view towards addiction. It's very hard, isn't it? I mean, we're all, I mean, as callous as it might sound to say this, people are more comfortable working with cancer patients, children with illnesses, people with, you know, renal failure. How many of us are comfortable working with addiction issues? And there are many reasons for that, right? And there's this really interesting quote that I came across, which I think sums it up. If mental health is the poor sister of the healthcare system, then addiction is probably the second cousin who lives in the slums. That's how we treat addiction. That's how we treat addicts. That's how we treat substance users. We don't want to look at them. We don't want to talk about them. They must be terrible people. They must have, you know, a very warped value system if they're taking drugs. So how many of us, and this is an introspective question that I'll ask you to reflect on, how many of us are comfortable working with people who have addiction issues? Rather than asking what someone is addicted to, I'm going to ask you to try and look at this perspective. Rather than asking what someone is addicted to, when they got addicted, or for how long, try asking them this. What does it offer you? What do you like about it? What in the short term does it give you that you craved or liked so much? How many of us are comfortable enough to sit across from an alcoholic and have this conversation? How many of us are willing to sit across somebody who has a heroin habit and ask these questions? But there is somebody who has asked these questions. He's written a book about it. And I'm going to tell you what that book is. But universally, the answer you'll find will be one of these. It helped me escape emotional pain. It helped me deal with stress. It gave me peace of mind. It gave me a sense of control. It helped me to connect with others. In some way or form, these are the answers you are going to get from the person that you ask those questions to. So I'm going to read out a paragraph from, this is the man who asked these questions, Gabor Mate. And this is the book that I would recommend anybody who's interested in addiction issues to read, In the Realm of Hungry Ghosts. So he says, such responses illuminate that addiction is neither a choice or primarily a disease. It originates in a human being's desperate attempt to solve a problem, the problem of emotional pain, of overwhelming stress, of lost connection, of loss of control, of a deep discomfort with the self. In short, it is a forlorn attempt to, sorry about all those P's, solve the problem of human pain, all drugs and all behaviors of addiction, substance dependent or not, whether to gambling, sex, the internet, or cocaine, either soothe pain directly or distract from it. The question is not why the addiction, but why the pain. When we talk about palliative care, we talk about pain relieving, right? We talk about taking away somebody's pain. We've all talked about the idea of total pain, pain that the person's life circumstances contribute to his experience of pain. But we also I think we have the responsibility of looking at what is causing somebody emotional pain if we are to really, really provide them compassionate care and palliative care, right? So that's going to take us getting out of our comfort zone a little bit and really sitting across somebody who has an addiction issue and understanding what is causing them that pain. So we just have a few minutes, but I'm going to sort of just bring your attention to an emerging shift from criminalization and abstinence to harm reduction. Some of us are not familiar with the idea of harm reduction. We are all familiar with the idea that to take drugs in a lot of our countries is going to land us in trouble or put us in jail, or in some countries like the Philippines, it's a death penalty. And typically the view for addiction is abstinence. What do you want for a drug addict? For someone who uses drugs? First of all, I also have to correct myself. That terminology is politically quite incorrect now. We don't call them substance users or drug addicts. We call them people who take drugs. So what do we typically want for a person who takes drugs? We want them to stop, right? We want them to stop. We want someone who drinks to stop drinking. We want a smoker to stop smoking. We want a heroin user to stop taking heroin. That is what we as a society want for them. How successful have we been as a society so far? I would say not very. Because abstinence, getting someone to stop completely, is literally like, if you ask a person who takes a particular substance to stop taking it, it's like actually going in and trying to break up a relationship. They're going to resist you. Very few people might have the resolve to get out of it on their own. But today there's a new concept of harm reduction. A person is going to continue taking drugs till they want to stop. So at least we can reduce the harm they cause to themselves and to people around them. An example of harm reduction is a needle exchange program that is now underway in a lot of countries. When somebody who takes injectable drugs, a lot of the fallout from that is that they might get HIV because they share needles. There were some places where they hiked up the price of syringes because they didn't want drug users to go and buy syringes. So that was actually counterproductive, because what these people then did was reuse the same syringes or share syringes, therefore increasing the outbreak of HIV. So what a harm reduction program would do is a person who uses injectable drugs would come in, give them the used syringes, and they get fresh syringes in return. The argument for that is you're encouraging them to take drugs. No, we're reducing the harm of them getting HIV. It's harm reduction. So harm reduction is a very, very interesting area that is emerging. It's really going to be counterintuitive to a lot of us when we read about it, but it has been known to be one of the most successful, if not the only successful long-term program for drug users. An interesting thing that happened in Portugal a few years ago was the country Portugal as a whole decriminalized all drugs. You were no longer a criminal if you took any drugs. Do you know what the outcome of that was? Not only did they decriminalize it, they said, you know what, these people who are taking drugs, let's not put them in jail. Let's give them jobs. Let's go back and find out what is causing them the pain that is making them take the drugs. And they found that once they got them engaged in the community, there were support groups, there was vocational training, that these people actually on their own stopped taking drugs to a large extent. There was almost a 50% drop in injectable drug use in Portugal within a year. So that's, I mean, it might seem counterintuitive, but it works. So if you're interested in working in this line, then, and I think definitely palliative care should look at people who use drugs. This is something that we need to look at. So that's the example of Portugal. And I'm going to end with a quote that I love very much from this wonderful human being called Johann Hari. And he says the opposite of addiction is not sobriety. The opposite of addiction is connection. And there's this incredible TED talk that he's given. Look out for him, Johan Hari. Look for that TED talk. He's going to actually highlight a lot in that TED talk. He highlights a lot of the stuff that I was talking about. And today he's one of the seminal voices in substance use and depression. So I think we can all learn from it. I know a lot of the things that I've talked about today are outside of the zone of traditional palliative care, but that doesn't mean that we ignore these people who have this kind of suffering as well. So we've been all over the map. So I am done with 2 minutes to spare, Raju. And
thank you so much, ma'am, for this wonderful session. So I think this is the time to have further clarification regarding. We are so sorry.
There's some construction work going on in Pallium India facilities, so I think it's more painful for people there on a daily basis than.
Yeah. So this is the time to have raise your questions, queries, any clarifications needed regarding the particular session. Please go ahead. Please raise your hand so that we can unmute. Yes, CCF team, please.
Yeah, ma'am, we saw about addiction. So, is it like about addiction leading someone to palliative? No, right? Are there chances like that?
Pardon me, sorry?
Someone with the substance addiction, will it lead them to a state of palliative?
Absolutely, absolutely, absolutely. You'll find that especially injectable drug users, there tends to be a triangle that is very common. Injectable drug users, sex work and HIV have a very, very strong correlation. Okay, again, because of what I talked about, sharing of needles and so on very often leads to people getting HIV, and people with HIV. A lot of us in palliative care work with people with HIV, so there is a connection there. That's a roundabout connection. I'm not for a moment implying that anybody who has HIV has used drugs in the past. It's not that, but apart from the more obvious sort of palliative care traditional practices, we talk about illness-related suffering in palliative care, right? We talk about that. We talk about how somebody's, when there's one person in the family who's going through a particular health crisis, it affects the whole family. My question really to this group is, why are we not looking at people who are taking substances? Because it has a huge impact on the family as well. And this is also well within the realm of illness-related suffering. So I know that the connection between substance use and palliative care is a new one, and a lot of us are probably hearing about it for the first time. But I think it is definitely something that we need to look into. I think my colleagues and friends from the northeastern states of India are far more familiar with some of the issues that they face, like in Mizoram and in Meghalaya and stuff. There's a huge population of people who are receiving palliative care, and a lot of those people have come to have these illnesses because they've been in this particular circle of substance use. So there is a connection, and if you look into it, you'll find it. And I generally feel that also palliative care as a discipline, we tend to take on people who the rest of society is not looking at, the invisible patients in our society. And one of the most marginalized groups, culturally, socially, are people who take drugs. So definitely there is space for us to work within that. It's an evolving field, but the person who wrote that book, Gabor Mate, he not only is he a de-addiction specialist, he spent 20 years in palliative care. And that's another reason why I think anybody who's interested in this should read his book, because there is a very, very clear convergence and synergy between palliative care and harm reduction and working with people who use drugs.
Thank you.
Thank you, ma'am. Any other queries?
Shalini.
Shalini, please.
Hi, Smriti. Thank you so much for a wonderful session. I think it really opened up my own mind so much about addiction and the way we treat people. I just got a question when you were explaining the different types of addictions and how the disorders and all. Do you think the steroids used by the sports people, that also would fall under any kind of obsessive disorder, or because that also gives a rush for better performance, it is given? So will that also fall under what you explained in the beginning?
I'm not so sure if it falls under psychological addiction in that sense. It's more a performance enhancement issue, and that is arising from a different motivation altogether, I suppose. It's about the win. But that's an interesting question, Shalini. I'm glad you brought it up. I suppose the addiction is to the fact that the person needs to win, or the person needs to do better,
Yeah.
and this becomes a list. So I don't know if the question would be, is there a craving for that drug? If there's no craving for the drug, then the issue of psychological addiction is not there, because craving is a very, very important component to diagnose addiction as a condition.
I'm not too sure if it is just me. I can't hear you very clearly. The voice is breaking.
Can you?
Is it just me, or Raju? Is it with everybody?
We could hear it clearly, ma'am.
I can't hear you at all, Smriti.
I think Shalini, you have some network connection there, issues there. We can hear you properly.
Okay, probably that's my connection. Must be wrong.
I'll still attempt to answer the rest of Shalini's question. Is use of performance enhancement drugs considered the same as addiction? My personal opinion would be no, because when they're not taking the drug, do they have a craving for it? No, they take it for the specific purpose of enhancing their physical performance in a sport. So yeah, so I think that's, to me, it would not be an addiction disorder in that sense. But I mean, again, like I said, I'm also new to this field. So that's something that I'll definitely look into and give you guys a more definitive answer.
Thank you, Shalini, for raising that question, and thank you, Smriti ma'am. Any other questions? Rana Kumar sir.
Ma'am, one thing, it is a saying that taking limited alcohol daily will give me health status well. It is a saying. So whether we can, but they are addicted to alcohol, but not with a limited amount. Whether we can tell that it is addict, or we can tell that no, it is for the health consciousness.
Thank you very much. Actually, that's a question I was hoping somebody would ask. I'm just going to backtrack a little bit. In our own practice, sometimes, my earlier, when I was younger, very few of us really made the distinction between a full-blown alcoholic, a social drinker, and somebody who occasionally drank, or somebody who came home and had 2 small pegs in the evening to relax. The tendency is for us to paint everybody with the same brush. When we go into somebody's home and then the wife might tell us, yeah, my husband drinks, we instantly, I've seen it happen, which we've corrected on several occasions, where it gets put down as husband is an alcoholic. That's not true. There are functional alcoholics. There are dysfunctional alcoholics. There are social drinkers. There are people who just, have it once in a while to relax. So we really need to then dive deep into our own understanding of this. Is it abuse? It's not abuse. If somebody comes home after a long day and has a beer, it's not abuse. Is he causing trouble to his family? No, he's not. Is he being an absolute nuisance? No, he's not. There might be dependence, sir, to alcohol in that sense, where also there's a dependence saying that, okay, I need this one glass or whatever to relax in the evening, and there is a physical dependence that the body might have for it. It could be a psychological thing that, I need this one thing to relax, and then you relax and it's done. But I'm glad you raised this question, because how many of us, without meaning to, are quite cruel in our judgment of somebody just because they take alcohol. I mean, it's really cruel. And one of the things that I've learned through whatever experience I've had with addiction issues is that the minute that judgment comes in, you've lost the person you're trying to help. You've lost that person. The minute you say, what you're doing is terrible, there is no way that person's going to take help from you anymore. Which is why I said, take a more compassionate view. Try and understand what is the person's distress that is leading them into this, right? And why is it that so many alcohol de-addiction programs fail? The world-renowned 12-step program, the relapse rate is extremely high. Very, very high. So to bring in judgment is, you are shooting yourself in the foot right from the start. So I would say we should understand, especially when we go into families where somebody is, somebody takes alcohol, whatever. Yes, alcohol is an issue. It causes distress to the family and whatever. But we also need to not label that person an addict immediately, and try and understand where they're coming from. And like I said, also make the distinction between functional alcoholics, social drinkers, and people who actually have a severe problem. So we need to be able to make that distinction. Thank you for asking that. I hope I answered your question to a certain extent. I think we need to unmute you. Yeah.
Sir, do you have any further questions? I think no. So thank you. Anyone else? I think we can ask from our team also. If anybody is having any question, please.
Vaishnavi, so I realized that I went all over the map with addiction, addiction as a whole, addiction issues within palliative care and so on. Like I said, it's an extremely large topic to bring into a 1-hour session. But if anyone has any particular questions about palliative care, opioids, and our setting, please go ahead and ask. I'll be happy to answer what I can.
So for that, ma'am, I would like to ask, few people are asking, have some doubts regarding if we are using the morphine tablets or any other opioids like morphine, they're addicted to that. So how much we can answer to that question, and how we are tackling that situation? If somebody is asking, somebody from, especially from the medical field itself, people are afraid to give or prescribe these kind of opioids to the patients. So they are saying one thing is they are mentioning about the side effects, and one thing is about this particular addiction. So
okay,
I would like
thank you, Vaishnavi. Yeah, that's a question that I'm sure a lot of people keep getting asked. Let's look at the context. When the NDPS Act came in 1985, it came in like this massive draconian law, right? And it came in with all these punitive actions. If you were found, if even a little bit was unaccounted for, it's 10 years in jail, this, that. So hospitals stopped stocking it. Nobody wanted to put themselves at risk for that. So from 85 to now, just without, if you're not constantly working with a particular drug, you lose practice, you don't know how to titrate it and so on and so forth. So let's accept the fact that a large part of the healthcare system today does not know how to actually titrate and use the drug. Okay, now of course people do know it. There are different training programs and stuff. The medical curriculum of India does not have, or it has pain management as a subject for 1 hour in 5 years. Physical pain management, right? It's a 1 hour subject in a 5-year program, and it is a non-examinable subject, which means you can pass it or fail it, nobody cares. Right? So that really also gives the message that, hey, managing somebody's pain is not important. If my education system tells me you can choose to learn it or not, we're not going to test you on it. What it's telling me is that it's not important. So that's the context, number one, that we're working in. Secondly, the people asking you these questions, rather than us getting defensive, this is an opportunity for us to educate them on exactly these issues, right? How would I answer them? I would show them the evidence. The evidence shows that oral morphine has minimal chances of addiction. It's all there. There are journals about it. The Lancet Commission report talks about it. The study in Kerala talks about it. So there is evidence, and we can point them in the direction of evidence and say, this is there. No, but we've heard it's addictive. That's hearsay. Let me show you the evidence which shows you that it's not. Let's also talk about the fact that the education system has not taught us how to use it. So why don't you come visit us, or why don't you visit a center where they're using morphine effectively and safely and see how it's done? In our own practice in India, how many overdose deaths have we heard of? The answer is 0. There's been 1 death from overdose, and that's been the caregiver of a patient, by the way, who committed suicide. So the evidence points in the direction of oral morphine actually not having addictive issues. There is also the other component where maybe it has benefited certain sections to promote this as a demon around morphine, because then people will start buying more expensive medication. There is also that possibility. So, but we won't take that on, because let's not get into hot water there. But I would point them in the direction of evidence, right? And I would invite them to come and see how a morphine trial is done, how beautiful a morphine trial can actually be, and the impact it can have on somebody who's in pain. I will also give them the statistics on misuse, which is largely in our favor.
Thank you, ma'am. So I think that the clarification is needed to the entire group, and thank you so much for that. So any other questions? Anil Kumar?
Yes, ma'am, I am audible.
Yes, yes. Do you have any questions to ask?
Yes, ma'am.
Yes, please.
Ma'am, I just want to know that many of the palliative care patients, guardian come and ask me for the alcohol. The patient was addicted for alcohol and now we are not giving him and he want to take it. So whether we will suggest him or not.
Let me understand, see if I've got the question right.
Ma'am, I just want to know, the patient was addicted with alcohol, but after the cancer, after they came in palliative care, the guardian are not allowed to give him. But the guardian asked me कि he wants some, so whether we give it or not.
I really don't want to say anything on a public forum that's going to get me into trouble, which I suspect this is going to get me into big trouble. It can. I would say if the man does not have too long to live, why not? I mean, I'm not saying go and get him drunk, but you know, if he's been an alcoholic all his life and he wants to have a glass of rum or whiskey or whatever, let him have it. I mean, of course, you'll have to check with the doctor about the drug interaction. But I'll tell you, like, I've worked in a couple of hospitals where it has been granted as a wish, and it has alleviated that man's mental health for that time being. So it's, you know, I've actually, there was a hospice I was interning at many years ago where the man, you know, he lost his vision and he was in terrible pain and all of that. And his wife was having such a hard time because, you know, now he was not being able to eat anything and he was not being able to, he was an alcoholic as well before he got diagnosed. And eventually the hospice team just sat down with him and asked him what he wanted. And he wanted a quarter bottle of rum and he wanted 1 plate of chili chicken. He was given it. It's not like he ate the whole thing, but just the fact that it was given to him just made him so happy. And it's not like he found himself blind. So I would say, I mean, it's complex. You'd have to also respect the family's wishes. I'm not, but I just want to make it very clear to everybody here that I'm not condoning, like, you know, peddling alcohol to our patients. But in this context, I would look at how long he has and I would honor his wish.
Thank you, ma'am.
Thank you, Anil, for raising that, and thank you, Smriti ma'am, for your answer. Any other questions or comments? Okay.
Anyone from Palium? Any questions?
Yeah. Any questions?
I think we keep having these conversations, so I don't.
So I think the mental addiction is something else. So that,
Psychological.
yeah. That is that we need to cure through medications or through some other thing.
Again, okay. So it might sound like a feeble excuse now, but I think what really has come through for me over the years is that rather than symptom controlling with medication, and I don't mean this just for addiction, I also mean this for stuff like depression. Very often the tendency is to give somebody an antidepressant, give somebody a, like some drug. And what that does is it only suppresses the symptom. The underlying source of the pain, when I say pain, I mean emotional, spiritual pain, is not being looked at. It's not being addressed. By giving somebody drugs to counter a problem will be effective if you're also concurrently looking at the underlying issue. I met this absolutely brilliant de-addiction specialist in Imhans who said to me, we don't admit people here against their will for several reasons, right? And the most important process in the whole de-addiction process is the psychological assessment. And once you go through the psychological assessment, there's a lot of psychological support. And I don't mean just venting of emotions, like actual psychological therapy techniques that are used concurrently. And those are the cases that actually have shown improvement. So medication use, of course, I will not disrespect. It has its place. But would it be the only line of tackling an issue? I disagree with that. Because a lot of this is a very human problem. Like, underlying a lot of alcoholism is depression. Underlying a lot of substance use is abandonment and lack of attachment, lack of connection. And time and again, evidence is showing that it's when you re-engage with these people, stop judging them, stop making them feel guilty, that's when they really start showing signs of improving. So we have a tendency to look down on people who use substances. And they feel it. They feel it. And this superiority complex, the self-righteousness that we as helpers sometimes has, is what is alienating us from them, is stopping us from helping them. So yeah, it's probably a roundabout question, answer to your question, but I personally say that the use of medication should always be supported by psychological intervention and support.
Thank you, ma'am. I think Ashla is also having some question.
Hi, Smriti. I just wanted to know, like, when we treat somebody in a family, there we understand that there is a history of alcoholism in that family, and then if there are children in that family, if there is something which we can do to prevent or help those children from becoming an addict. If we know that there is a good history of solid history of alcoholism in the family.
Thank you. I love that question. There is a lot we can do. There is a lot we can do. And if you remember the slide I showed on nurturing a child, that's something that we need to look into. If there is a known history of substance abuse or alcohol abuse in the family, I would really look to the children to understand what their relationship with their other caregiver might be. What is their relationship with the mother? What are there nurturing adults in the family apart from the person who's abusing or using the substance that they have a connection with? They are at higher risk for, like that slide very clearly said, they are at very high risk to seek chemical sustenance to make up for the lack of nurture. So we've also done a section on how to talk to children, right? That's where I would employ it. Sit down with a child, understand what they understand of the issue. See, but most importantly, find a nurturing adult with whom they can form a healthy attachment and who will then sort of make up for that loss of that proximal separation or whatever that they might be having with with the parent that is using a substance. So there is a lot that can be done, Ashla, and there are several ways to look at it. There are several theories that we can look at from a psychological perspective, but just in our work for people who are not trained in psychological interventions, the most basic human thing you can do is identify the adult in the family that can actually provide the nurture to that child. Educate that adult. It's not just enough to find the adult, it's also to educate the adult on what the outcomes can be with alcoholism in the family, and highlight the risk that the child potentially is at. And once you psychoeducate somebody, they're in a much better place to sort of fill that gap for you. So thanks, Asha. Thanks for that question.
Thank you, Smriti.
So yeah, so I think it's for 25. So one and last question, is there any clarifications needed? I think you can definitely reach out to Pallium India and ECO coordinator also to Smriti ma'am. So thank you ma'am, thank you so much for this wonderful session. It is so fruitful and useful for our practical work also. And thank you for mentioning the book and about Johann Hari. That will definitely enhance the knowledge level too. So
I'm happy to actually share that link with you guys, then you can share it.
Sure, please do. Yeah. So thank you all the participants, and I would like to inform you that this is my last facilitating session for Psychosocial Echo. I just got placed in another firm. It's a immediate recruitment, so I need to join tomorrow. So I'm so happy to have this initiative in Pallium India along with Rajalakshmi and Smriti ma'am. So thank you so much, each one of you. Thank you for your participation. This is one of the ECO program. We are having more than 75 or 85% of attendance regularly. So thank you each one of you for your support and cooperation, and looking forward for the successful completion of this session, and we will definitely continue this venture in future. Thank you.
Thank you, Vaishnavi. I just also want to say that you've done such a fantastic job of, you and Raju have just carried this whole thing through. So you're going to be very badly missed. And I think I can speak for all the participants when I say that. But thanks for everything that you've done to you've actually contributed hugely to the success of this program. So thank you. Thanks very much.